Welcome to the Concierge Care Health System podcast. The information shared in this podcast is for general informational purposes only and does not constitute medical advice. Listeners should be aware the content is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a physician or other qualified healthcare provider for medical questions.
Welcome to The Deep Dive. We're the show that digs into the research so you don't have to, giving you that shortcut to being, well, really well informed. Today, we are diving deep into something amazing, maybe a bit overlooked. Your cervical spine, your neck. I mean, just think about its job for a second. It's got this completely paradoxical role, right? It has to be this super strong foundation holding up your head, which, weighs about as much as a bowling ball, seriously. Wow. But at the very same time, it needs this incredible flexibility, like a huge range of motion so we can point our eyes, ears, nose, wherever we need to, separate from our body. So yeah, this dual thing, high mobility, plus protecting really vital stuff like the spinal cord, those vertebral arteries, it makes it uniquely vulnerable. It's amazing engineering, but also a complex spot.
Absolutely, and that duality, that's exactly why problems with the cervical spine have such big impact. It's actually kind of shocking when you look at the numbers. These aren't just, annoying aches. Cervical spine disorders are a major public health problem, huge socioeconomic burden globally. Just to give you an idea, neck pain, it's right up there among the top causes of disability worldwide. It's actually the fourth highest contributor to what they call years lived with disability, YLDs.
Fourth highest, wow.
Yeah, and the cost, well, it's staggering. In the U.S., back in 2016, low back and neck pain together, they were the single biggest category for healthcare spending. We're talking something like $134.5 billion. And that's not just like doctor visits and surgery. It's also the indirect costs, lost work time, productivity hits. It really affects everything.
That is a massive number. Really puts it in perspective, doesn't it?
All right.
How important neck health is. Okay, so let's unpack this then. Let's start with really understanding the engineering. What is our neck? Exactly. So the basics, it's built from 7 cervical vertebrae. And we usually split them into 2 main groups, right? The top bit, C1 and C2, which are kind of different.
Atypical,
right. And then the lower spine, C3 down to C7, which are more typical.
Exactly. And those top 2, C1 and C2, the atlas and the axis, they're really unique. C1 is basically a ring. No vertebral body like the others, no pointy bit at the back. And C2 has this peg-like thing sticking up called the dens. It acts like a pivot point for C1 to rotate around. What's really fascinating here is that the joint between them, the atlantoaxial joint, is responsible for something like 50% half of all the rotation in your neck, turning your head side to side.
50% just from those 2?
Pretty much. And the crucial thing is the stability there. It's almost all down to ligaments, like the transverse ligament, which of course makes it a point of, well, significant vulnerability if those get injured.
Okay, so C1 and C2 are the special ones. Then moving down C3 to C7, they look a bit more like typical vertebrae, but still have neck-specific features.
They do. They have smaller bodies. Their spinous processes, the bumps you feel on the back of your neck, are often bifid, meaning split in 2. And critically, they have these unique holes in their side projections, the transverse processes. These are called transverse foramina.
The tunnels.
Exactly, the tunnels. And they're vital because the vertebral arteries run up through them, carrying blood to the back of the brain. Super important.
Right. And between the vertebrae, the discs and joints.
Yep. You've got the intervertebral discs, the IVDs. And in the neck, they're actually quite thick relative to the bone height, maybe up to 40% of the total height.
40%.
Yeah, which is a big reason why your neck has such a great range of motion compared to, say, your thoracic spine. And then you have the facet joints where the vertebrae connect at the back. Plus, in the lower neck, these unique little joints called uncovertebral joints or joints of Luschka. They help guide motion, but they're also a really common place for bone spurs to form later on. Degeneration loves those spots.
Okay. And ligaments and muscles holding it all together.
Absolutely critical. Strong ligaments run up the front and back, the AL and PLL, though the PLL is a bit thinner on the sides, which is relevant later. And the muscles, well, they're basically working all the time because your head's center of gravity is actually slightly forward of the joints connecting it to the spine.
So they're constantly pulling back. Just slightly.
Exactly. Creates this perpetual forward bending moment that the muscles have to counteract just to keep your head balanced.
So all that structure leads to how it moves.
Yeah.
The kinematics.
Right. And neck movement is rarely just, one simple thing. It's usually coupled motion, bend your head sideways, and it tends to rotate a little bit too, automatically. And just for context, the levels where you get the most forward and backward bending, flexion, and extension in the lower neck, that tends to be around C4 to C6.
Now, here's something I found really interesting. That natural forward curve your neck has, the cervical lordosis, it's not just how it looks, it's like mechanically essential.
Oh, absolutely essential. That curve, usually somewhere between 20 and 40 degrees, is biomechanically vital. Think of it like a spring or a shock absorber. It lets the spine soak up and distribute the load from your head much more effectively, minimizes stress on any single disc or vertebra. Plus, it helps keep the spinal canal open.
Wow.
If you lose that curve, a condition called cervical kyphosis, where the neck straightens or even curves the wrong way, it totally changes the forces.
Puts more stress on everything.
Exactly. Increases stress, makes the spine more prone to wearing out faster. And speaking of stress points, that junction where your flexible neck meets your much stiffer upper back, the C7T1 junction, that's a real hotspot.
Why there specifically?
Because you have this abrupt change in mobility. The upper back is stabilized by the rib cage, it doesn't move much, so that transition point takes a lot of mechanical stress. That's why you often see more advanced degenerative changes and even fractures right there.
Okay, that makes sense. So let's transition then into those degenerative changes you mentioned. They're common, almost universal.
Pretty much, yeah. It's a near universal part of aging. And we talk about this degenerative cascade. It's a whole sequence of events. And interestingly, it often kicks off inside the intervertebral disc, sometimes, believe it or not, as early as the second decade of life, your 20s.
Seriously, in your 20s.
Yep. It starts with the disc losing water content desiccation. It gets less plump, less resilient, like a grape turning into a raisin, kind of. This loss of height and hydration puts weird stresses on the outer ring, the annulus, which can lead to small tears. Then ligaments might get a bit looser, the segment becomes a little unstable, and the body's response, it tries to restabilize by growing extra bone. Bone spurs or osteophytes on the facet joints, those uncovertebral joints.
Trying to lock things down.
Exactly. But that stabilization often comes at a price. The extra bone can narrow the spinal canal or the little tunnels where the nerves exit, potentially leading to nerve compression down the line.
And this whole process, broadly speaking, is cervical spondylosis.
That's the umbrella term, yeah. Covers all those age-related wear and tear changes.
But here's the really mind-blowing part, right? The disconnect between imaging and symptoms.
Yes. This is so crucial. You absolutely need to understand this. Just because we see these degenerative changes on an X-ray or an MRI, it does not automatically mean it's the cause of someone's pain.
Okay, lay the stats on us.
All right, so radiographic signs of spondylosis. You see them in about 25% of people under 40, jumps to 50% of those over 40, and up to 85%, 5% of people over 60.
85%, even if they feel fine.
Exactly, and MRI studies on totally asymptomatic people. A quarter of under 40s show disc degeneration, nearly 90% of over 60s.
Wow, so what does that actually mean then, clinically?
It means you cannot diagnose based on the image alone, ever. Finding spondylosis on a scan isn't by itself a diagnosis that explains pain. You absolutely need a thorough clinical evaluation. Talking to the patient, understanding their symptoms, doing a detailed physical exam. You have to correlate the findings. Is this change on the MRI actually causing the specific symptom, or is it just an incidental age-related finding?
Because treating the image instead of the patient
can lead to totally unnecessary tests, anxiety, and treatments that don't actually help. Big problem.
Okay, so when these changes do cause symptoms, what does that typically look like? What's common?
Most commonly, it's axial neck pain. Kind of a deep ache, maybe localized, maybe more spread out. Often worse when you're upright or moving, feels a bit better when you rest. Stiffness is really common too, reduced range of motion.
And sometimes the pain travels.
Yeah, it can be referred, sometimes up to the back of the head. We call those cervicogenic headaches. Or it might feel like it's in the shoulders or even between the shoulder blades.
Okay. And then there are disc herniations, specifically.
Right. That's when the inner, softer part of the disc, the nucleus, pushes out through a weak spot or tear in that tough outer ring, the annulus.
And they tend to go sideways and backwards?
Posterolaterally, yeah. That's the most common direction. Two main reasons. The annulus itself is just anatomically thinner and weaker back there and to the sides. And that posterior longitudinal ligament, the PLL we mentioned, it's narrower in the neck, so it provides less reinforcement right where these herniations often happen.
And depending on where it pushes.
Exactly. If it goes straight back centrally, it might compress the spinal cord itself. That can lead to myelopathy. We'll get to that. But if it goes posterolaterally or even further out into the nerve root canal, foraminal, it's more likely to hit an exiting nerve root. That causes radiculopathy, the pinched nerve.
And certain levels are more common.
Yeah, C5, C6, and C6, C7 are the most frequent spots for herniations, often affecting the C6 and C7 nerve roots, respectively.
Got it. And the last degenerative outcome is stenosis, the narrowing.
Correct. Cervical stenosis just means narrowing of the spaces within the spine. It can be the central canal where the cord lives or those lateral foramina where the nerve roots exit. And often, yeah, it's kind of the end result of that whole degenerative cascade, the discs collapsing, the ligaments thickening, the bone spurs growing. It all conspires to reduce the available space.
Okay, let's shift gears a bit. What about when things go wrong more suddenly? Traumatic injuries.
Yeah. Trauma to the cervical spine is always taken extremely seriously because you're dealing with potential damage to the spinal cord, the risk of, severe neurological problems, even death is high.
And these are usually high-impact events.
Typically, yes. Things like severe flexion, extension, or axial compression, like a heavy force straight down the spine.
Are there specific injury patterns people should know about?
Well, in the upper cervical spine, some classic ones are the Jefferson fracture. That's a burst fracture of the C1 ring, often from diving into shallow water, that kind of axial load, and odontoid fractures, fractures of that dens peg on C2. Type 2, right at the base of the dens, is the most common and notoriously unstable, partly because the blood supply there isn't great for healing.
Okay. And what about whiplash? Everyone's heard of whiplash.
Right. Important clarification here. Whiplash-associated disorder, or DUIA, isn't really a diagnosis of a specific tissue injury. It's the mechanism.
The way the injury happened.
Exactly. It's defined as an acceleration-deceleration energy transfer to the neck. The classic example is a rear-end collision.
Right, your body gets thrown forward.
But your head lags behind because of inertia. It forces the neck into this unnatural S shape, then it snaps backward into extension and then forward into flexion. A complex, rapid movement.
And there's a grading system for this.
Yes. The Quebec Task Force, or QTF, classification, grades 0 to Valavi based on symptoms and signs, helps standardize things. But what's really become a focus of research is chronic WOD, because while a lot of people get better relatively quickly,
some don't.
A significant number, maybe up to half in some studies, develop persistent pain and disability. And here's the puzzle. Often, their standard imaging, like MRIs, doesn't show any ongoing major tissue damage that explains it.
So, why does the pain stick around?
The leading theory now points towards central sensitization.
Okay, what is that exactly?
It's basically a change in how the central nervous system, the spinal cord and brain, processes pain signals. It becomes hyperexcitable, kind of like an amplifier turned way up.
Like the volume knob is stuck on high.
That's a great analogy. So, stimuli that normally wouldn't be very painful feel much worse. That's hyperalgesia. And sometimes things that shouldn't hurt at all, like light touch or the pressure of clothing, can become painful. That's allodynia. The pain can also spread beyond the initial injury site.
So the problem shifts from the neck tissues to the nervous system itself.
Precisely. It's a neuroplastic change. Understanding this is critical because it means management has to address these central nervous system changes, not just keep looking for a fixable problem in the neck tissues that might have healed months or years ago.
That's a huge shift in thinking. Okay. Beyond trauma and degeneration, are there other, maybe less common but important causes?
Definitely. You have inflammatory conditions, things like rheumatoid arthritis or ankylosing spondylitis can affect the cervical spine. Then there are infections. Bacteria can infect the vertebrae, osteomyelitis, or the discs, discitis, not common but serious, and neoplastic conditions, tumors. These can be primary bone tumors or, more commonly, cancer that has spread metastasized to the spine from elsewhere.
And for these, doctors look for specific warning signs. Red flags.
Absolutely crucial. Red flags are clues that suggest the neck pain might be caused by something more serious than typical mechanical issues. They tell us we need to investigate urgently. Probably the single most critical red flag, especially for a potential tumor, is non-mechanical pain.
Meaning pain that isn't related to movement.
Exactly. It's often constant, deep, boring pain. It doesn't get better with rest, might even be worse at night or when lying down. That's very suspicious.
What are some other key red flags?
Things like a prior history of cancer, unexplained weight loss, fever, chills, night sweats suggesting infection or sometimes malignancy, recent bacterial infection elsewhere like a urinary tract infection, anything that suppresses the immune system. IV drug use is a risk factor for infection, and importantly, any neurological symptom that is progressively getting worse.
If the others pop up.
It warrants immediate investigation, usually starting with blood tests and often an MRI, probably with contrast dye, to get a very clear look and rule out these serious conditions quickly.
Okay, so we've talked about all these different things that can go wrong: degeneration, trauma, infection, tumors. But ultimately, how do they cause the symptoms someone feels?
Right. They cause symptoms primarily by affecting the neural elements housed within the spine, either the spinal cord itself or the nerve roots branching off it, through compression, irritation, inflammation.
And this leads to what you said is the most critical distinction clinically.
Yes. This is probably the single most important concept to grasp when evaluating neck and arm symptoms, differentiating cervical radiculopathy from cervical myelopathy.
Okay, break those down for us. Radiculopathy first, the pinched nerve.
Exactly. Cervical radiculopathy means there's a problem with a spinal nerve root. It's being compressed, irritated, or inflamed right as it's trying to exit the spinal column through that foramen, that bony tunnel. And the most common causes, back to our old friends, degenerative changes, usually a disc herniation pushing on the root, or bony spurs, osteophytes, narrowing that exit tunnel, known as foraminal stenosis.
And what does radiculopathy feel like?
The hallmark is pain that radiates down the arm from the neck, and it typically follows a pretty specific pattern corresponding to the territory, the dermatome, supplied by that particular nerve root. The pain is often described as sharp, shooting, electrical, or burning. Plus, you often get sensory symptoms, tingling, pins and needles, numbness in that same distribution, and sometimes motor weakness in the muscles supplied by that root.
Can you give an example?
Sure. Let's say you have a herniation at the C5, C6 level, which commonly affects the C6 nerve root. You might feel pain, numbness, or tingling running down the outer part of your arm into your forearm and specifically into your thumb and index finger. You might also notice some weakness when you try to bend your elbow using your biceps or when you lift your wrist up.
Okay. And C7 root.
C7 radiculopathy, usually from a C6, C7 lesion, classically causes pain or altered sensation down the back of the arm and forearm, often into the middle finger. The characteristic weakness is in the triceps, muscle difficulty straightening your elbow against resistance.
Right, so that's radiculopathy, a nerve root problem. Now, myelopathy, what's different?
Cervical spondylotic myopathy, or CSM, is fundamentally different. It's not a nerve root problem, it's a problem with the spinal cord itself. It's spinal cord dysfunction caused by chronic compression within a narrowed central spinal canal. Much more serious.
And how does that compression actually damage the cord?
It's kind of a double hit. There's the direct mechanical pressure from things pushing on the cord disc, bulges, bone spurs, thickened ligaments, static compression. But there are also dynamic factors. When your neck moves, even with normal motion, if the canal is already tight, the cord can get repeatedly stretched, sheared, or bunked because it has no room to glide safely. Repetitive microtrauma. This combination compromises the tiny blood vessels supplying the cord, leading to chronic ischemia, reduced blood flow that causes inflammation, nerve cell death, and eventually the cord tissue can soften or scar. That's myelomalacia.
Okay, and the symptoms of myelopathy are different from radiculopathy.
Very different, and often much more subtle, especially early on. It typically creeps up insidiously. People might just feel like they're getting clumsy or attributing symptoms to getting older. The classic picture is a mix of signs. You get upper motor neuron signs below the level of the compression. Think problems in the legs, stiffness, spasticity, jumpy reflexes, maybe a positive Babinski sign. Gait and balance problems are really common, feeling unsteady, needing a wider stance, increased risk of falling.
So leg issues from a neck problem.
Exactly, because the signals going down the cord to the legs are affected. But at the level of the compression in the neck, you might see lower motor neuron signs. This often manifests as problems with the hands, loss of fine motor skills, clumsiness, difficulty with buttons, handwriting changes. Weakness and visible wasting or atrophy of the small muscles in the hands can occur.
And bladder issues.
Bowel and bladder dysfunction can happen, but they tend to be later findings in the progression.
So recapping that crucial distinction.
Radiculopathy, peripheral nerve root problem. Painful, yes, but often has a favorable natural history. Most cases, maybe 85% or more, get better with conservative treatment over weeks to months.
Myelopathy.
Myelopathy, central nervous system problem. Spinal cord dysfunction, it does not get better on its own. The natural history is typically one of stepwise neurological decline. Things might stay stable for a while, then worsen, then stabilize, then worsen again. but the overall trend is downhill.
And the implications for treatment are huge.
Absolutely massive, because if left untreated, myelopathy leads to progressive disability, often irreversible. So a diagnosis of progressive myelopathy is generally considered an indication for surgery. And the main goal of surgery isn't always to make existing symptoms dramatically better, though sometimes that happens. It's primarily to stop the deterioration, to halt the progression of neurological decline.
So delaying surgery can mean a worse outcome.
Yes. Any significant delay in treating progressive myelopathy can unfortunately result in a worse final neurological status for the patient. Timely diagnosis and intervention are key.
Okay, that distinction is crystal clear now. Radiculopathy versus myelopathy. Huge difference. So how do doctors figure all this out? What's the diagnostic process?
It always starts with the clinical evaluation. That's the bedrock. A detailed history listening carefully to the patient's story, the pattern of symptoms, the timing. And crucially, screening for those red flags we talked about earlier to rule out urgent issues. Then, a comprehensive physical exam, looking at range of motion, checking muscle strength, sensation, reflexes throughout the upper and lower limbs.
Are there specific exam findings that point one way or the other?
There are some clues. For instance, if lifting the arm and placing the hand on top of the head relieves the arm pain, that's called the shoulder abduction relief sign, it's quite suggestive of radiculopathy. And we use provocative tests. Sperling's test involves gently compressing the head while it's tilted and rotated towards the painful side. If that reproduces the radiating arm pain, it points towards nerve root compression.
And for myelopathy?
Signs like Lermit's sign, that electric shock sensation down the spine or limbs when you bend your neck forward, indicate cord irritation. Hoffman's sign, where flicking the patient's middle fingernail causes an involuntary flexion of their thumb and index finger, suggests upper motor neuron hyperexcitability, a common finding in myelopathy. Hyperreflexia, the Babinski sign, gait changes, those are all key myelopathy signs.
Okay, so clinical evaluation first, then imaging comes in.
Yes, imaging plays a crucial role, but after the clinical assessment helps guide what we're looking for.
What are the main types? X-rays?
X-rays are often the starting point. Good for overall alignment, seeing that lordotic curve or if there's kyphosis. Checking bone quality, looking for obvious arthritis, fractures, or instability. We can also do flexion extension X-rays where you bend your neck forward and back to see if there's abnormal movement between vertebrae.
Then CT scans.
Computed tomography CT gives much better detail of the bone. It's the best choice in acute trauma for seeing complex fractures and how much the canal might be narrowed by bone fragments. It's also better than X-ray for seeing bony narrowing in those nerve root tunnels, the foramina.
But for soft tissues and nerves?
MRI is the gold standard. Magnetic resonance imaging, no radiation, and it gives beautiful pictures of the discs, ligaments, spinal cord, and nerve roots. MRI clearly shows disc herniations, how severe stenosis is, whether ligaments are torn. And critically, it can show signal change within the spinal cord itself, a bright spot on certain sequences, T2 weighted images. That signal change usually means edema, inflammation, or even scarring, myelomalacia, in the cord, which is a strong indicator of cord injury or compression.
So CT for bone detail, MRI for soft tissue and nerve.
Exactly. They're often complementary. In trauma, CT shows the broken container. MRI shows the injured contents.
What about nerve tests, EMG?
Electrodiagnostic studies, electromyography, EMG, and nerve conduction studies, NCS, are functional tests. They assess the electrical health of the peripheral nerves and muscles. EMG can directly detect signs of nerve damage, denervation, in specific muscles, which can help confirm which nerve root is affected in radiculopathy and rule out other nerve problems. NCS mainly helps differentiate radiculopathy from other things like carpal tunnel syndrome or other peripheral nerve entrapments.
Okay, so you've got the diagnosis. How do we manage these conditions? Let's start with conservative, non-surgical option.
Right. For the vast majority of people with just axial neck pain, and for many with cervical radiculopathy, conservative management is the first step and often very successful. And the approach has really shifted over the years. It's much more about an active multimodal strategy now rather than just rest and collars.
What does that involve? Medications.
Pharmacotherapy has a role. NSAIDs, nonsteroidal anti-inflammatories like ibuprofen or naproxen are common for pain and inflammation. Sometimes short courses of muscle relaxants if there's a lot of spasm, or maybe oral steroids for a severe flare-up of radicular pain. For nerve-type pain, that burning, shooting radicular pain, different medications often work better. things like gabapentin or pregabalin, or certain types of antidepressants, which also modulate nerve pain pathways.
What about opioids?
Generally, opioids are not recommended for long-term management of chronic neck pain. The risks usually outweigh the benefits. They might be used very short-term for severe acute pain, but that's it.
And physical therapy, you said it's a cornerstone.
Absolutely. PT is huge. It starts with education, understanding the condition, learning good posture and ergonomics for daily activities. Avoiding prolonged rest is key. Movement is generally good. Cervical collars are rarely helpful long-term. Exercise programs focus on range of motion, stretching tight muscles, and crucially strengthening the deep stabilizing muscles of the neck and the muscles around the shoulder blades. Manual therapy techniques like joint mobilization or sometimes manipulation by trained therapists can help restore movement and reduce pain. And for radiculopathy, mechanical or manual traction might provide some relief by temporarily opening up those nerve spaces.
So staying active is key.
Very much so. And rehab is also vital after surgery, of course, to regain function.
Are there other non-surgical options? Injections?
Yes, interventional pain management techniques can be helpful. For severe radicular arm pain that isn't getting better with PT and meds, cervical epidural steroid injections are an option. Using X-ray guidance, a potent anti-inflammatory steroid is injected right near the inflamed nerve root in the epidural space. The goal isn't a permanent fix, but to calm down the inflammation and pain significantly enough, give a window of opportunity so the patient can then engage more effectively in their physical therapy program.
Okay. But sometimes conservative treatment isn't enough or isn't appropriate. When is surgery considered?
Surgery comes into play generally if conservative management fails after a reasonable trial, usually 6-12 weeks for radiculopathy, or more urgently, if there's evidence of significant or progressive neurological deficit like worsening weakness, certainly for progressive myelopathy, as we discussed, also for intractable, unbearable pain that's destroying quality of life, or if there's significant spinal instability.
And you mentioned a shift in surgical approaches towards motion preservation.
Yes, that's a major theme. For decades, the standard for many degenerative conditions was decompression, taking pressure off nerves cord, followed by fusion, making bones grow together. Now, there's a strong interest in preserving motion at the surgical level when possible and appropriate.
So what are the main surgical options? Let's start with the classic ACDF.
Right. Anterior cervical discectomy and fusion, been the workhorse for ages. Surgeon goes in from the front of the neck, removes the problematic disc and any bone spurs pinching the nerves or cord. Then they put a spacer, usually a cage filled with bone graft material, into the empty disc space, and typically fix it with a small metal plate and screws. The goal is for the vertebrae above and below to fuse into one solid piece.
Advantages. Disadvantages.
Main advantages. It's a direct way to get pressure off the front of the spinal cord and nerve roots. It's very effective at decompression. It can also help restore that natural lordotic curve if it's been lost. Disadvantages? Well, you lose motion at that level, obviously. There's a theoretical risk that fusing one level might put extra stress on the adjacent levels above and below, potentially causing them to degenerate faster down the road. That's called adjacent segment disease, or ASD. There are also smaller risks like difficulty swallowing dysphagia temporarily or the fusion not healing properly, pseudoarthrosis.
So the alternative is disc replacement, CDR.
Cervical disc replacement, or cervical arthroplasty, yes. Instead of a fusion cage, an artificial disc prosthesis is implanted, designed to maintain motion similar to a natural disc. For the right patient, usually younger people with soft disc herniations or stenosis at only 1 or 2 levels, without significant arthritis or instability, CDR can provide outcomes as good as, or maybe even better than, ACDF in terms of function and potentially lowering the risk of that adjacent segment problem.
But it's not for everyone.
Definitely not. Patient selection is really strict. And there are other considerations like the possibility of extra bone forming around the implant, heterotopic ossification.
Yeah.
And we just don't have the super long-term data on wear and tear over many decades yet.
Okay, those are anterior approaches. What about from the back? Posterior.
Several options from the back. A laminectomy and fusion involves removing the bony roof over the spinal canal to give the spinal cord lots of room. Because removing that bone can destabilize the spine, it's almost always combined with a fusion using screws and rods.
All right, pros and cons.
Pro. It provides very wide decompression, especially useful for multi-level stenosis. Can also be used to correct deformity. Con. It's generally a bigger operation than an ACDF, more muscle disruption, potentially more post-op pain, and a risk of long-term neck pain or failed fusion.
Is there a motion-preserving posterior option?
Yes, Laminoplasty. This is a really elegant technique. Instead of removing the lamina, it's hinged open like a door either on one side or both, and held open with tiny metal plates or spacers. This widens the spinal canal to decompress the cord, but preserves more of the natural anatomy and avoids fusion. It's a great option for multi-level stenosis in patients who still have good neck curvature, lordosis, and don't have major neck pain or instability issues.
And one more, for just a single pinched nerve.
Posterior cervical foramenotomy. This is often done minimally invasively. The surgeon makes a small incision at the back and removes just enough bone and ligament around the nerve exit, the foramen, to take pressure off that single pinched nerve root. Effective for radiculopathy from a lateral disc or foraminal stenosis, and the big advantage is it avoids fusion altogether.
Wow, lots of options. Okay, briefly, how does management differ for those other conditions? Trauma, infection, tumors?
Quickly, yeah. Trauma, it all depends on stability. Stable fractures might just need a brace. Unstable fractures, or any fracture causing nerve or cord compression, usually needs surgery to stabilize the spine, often with plates, screws, or rods. Infections, osteomyelitis fasciitis. The main treatment is long-term intravenous antibiotics, typically at least 6 weeks, targeted to the specific bacteria identified from a biopsy or blood culture. Surgery is reserved for specific situations like a spinal epidural abscess compressing the cord, significant instability, major deformity, or if the infection just isn't clearing with antibiotics. Spinal tumors. This is complex, always multidisciplinary. For metastatic cancer that spread to the spine, radiation therapy is often the first line to control pain and shrink the tumor. Surgery is considered mainly if the spine is unstable, if there's neurological worsening despite radiation, or if the tumor type is known to be radioresistant. Often the goal of surgery is palliative to decompress the cord, stabilize the spine, and maintain function and quality of life, rather than aiming for a cure.
Okay, so pulling this all together, what are the big takeaways for someone listening? What should they really remember from this deep dive?
I think a few key things. First, appreciate the neck's design, elegant, incredible range of motion, but inherently vulnerable because of that. Second, that critical disconnect between imaging findings and symptoms. Remember those stats. Degeneration is common, even without pain. So the clinical evaluation, your story, the physical exam is absolutely paramount. Don't just treat the picture.
Right, don't chase the MRI.
Exactly. And third, maybe the most crucial clinical point, understanding the profound difference between radiculopathy, pinched nerve root, often gets better, and myelopathy. Spinal cord compression, progressive, needs timely intervention. Knowing that difference is vital.
And we've seen a real evolution in treatments too, right? Moving towards more active rehab, less passive stuff.
Yes, a big shift towards active, patient-centered conservative care. And in surgery, while fusion still has its place, there's definitely an embrace of motion-preserving options like disc replacement or laminoplasty when they're appropriate for the patient.
It really sounds like a team effort is needed.
Oh, absolutely. Optimal outcomes really depend on a collaborative, multidisciplinary approach. Your primary care physician, maybe a physiatrist, rehab doctor, physical therapist, radiologist interpreting the images, pain management specialists, and of course, orthopedic or neurosurgeons if surgery is needed. They all need to communicate and coordinate care effectively. It ensures patients get the right treatment at the right time.
That's such an important point. Which leads me to a final thought for everyone listening. Kind of a provocative question, maybe. With all these advances we've talked about, better understanding, better imaging, better techniques, what do you think the future really holds for neck pain? Could we actually get to a point where we don't just manage the symptoms, but we actually stop or even reverse the degeneration itself?
That's the million-dollar question, isn't it? And it points towards future research directions. People are actively working on biologics, things like growth factors, maybe cell-based therapies, using stem cells that could potentially intervene directly in that degenerative cascade within the disc. Imagine being able to actually heal a degenerating disc, not just manage its consequences. And combining that with continued refinements in minimally invasive surgery, better preoperative planning, using advanced imaging and biomechanical modeling, maybe even bringing in genetic factors to understand individual risk. It really does point towards a future of more personalized medicine, tailoring the strategy precisely to each person's unique situation.
A future where treatment is truly customized. That is definitely something worth exploring. Well, we hope this deep dive has given you that shortcut, make you feel well informed about your truly amazing neck and everything that goes on inside it.
Concierge Care, providing world-class, personalized care for patients and members. Taking a proactive approach by offering its free digital health clinic for anyone in need of these services. Reach out to us via our website, www.health.conciergecare.net, or give us a phone call at 786-809-2345.